ahead and get started. I want to make sure you all have time to talk in the tables afterwards, but we do want to get started. As I pointed out earlier, I am an impromptu, out-of-the-blue moderator, right? So this is the easiest part of the job. I get to say, Pat Allen will now speak to you. Ta-da! Pat, take it away.
Thanks, Kathleen. I appreciate you and the State of Reform team inviting me here today. And thank you all for being part of Oregon's healthcare community and being here. Like any community, all of us, whether we're a provider, a payer, policymaker, need to work together to navigate the changes and challenges that we face. We might not always agree on the right path to follow at any given time, but we're connected by a common commitment to ensuring everyone in Oregon can live a healthy life. And we carry a shared responsibility to advance Oregon's spirit of healthcare transformation. We've accomplished a lot together. In Oregon, we've attained 95% healthcare coverage. Oregon's coordinated care organizations have set the pace for Medicaid innovation, reducing avoidable emergency department visits by connecting more Oregon Health Plan members to primary care clinics. When the global pandemic came for our state, our communities, and our families, we banded together and took responsible, science-based action. As a result, Oregon had one of the lowest COVID-19 death and hospitalization rates in the entire country. Absolutely. But today, we faced a host of real and urgent problems. Our healthcare workforce is worn down, tired out, and overwhelmed. Too many people in Oregon still lack health coverage. The cost of healthcare is rising faster than inflation. Our historically underfunded behavioral health system can't retool fast enough to meet the needs of an escalating number of people in crisis despite new funds. The toxic impact of disinformation and polarization has led to threats against healthcare and public health workers. And underlying all these issues is the stark and unacceptable reality of health inequity. Everyone in this room can agree, in Oregon, no one should be born saddled with an unfair burden of facing a higher chance of infant mortality, living with chronic disease like asthma or diabetes, or being exposed to pollutants in your air or drinking water because of your race, ethnicity, your zip code, or the language you speak at home. But on most measures of health and well-being in our state, people of color experience avoidable and preventable disparities based on long-standing and centuries-old societal inequities that translate into shorter lifespans, lost opportunities, and physical and emotional distress. These consequences are not the result of personal decisions made by real people. Instead, they're caused by the policies and priorities pursued by our institutions. So today, I want to talk about the most important factor needed to repair our relationship with our fractured communities, restore our burnout workforce, and regain the momentum of health transformation in Oregon. That factor is trust. And to gain trust, we need to share power. That means listening to the priorities of people in our communities. It means letting go of old solutions to find new ones. Sometimes it even means getting out of the way so communities can take the lead in making key decisions and allocating resources. Let me start by talking about 3 examples of ways the Oregon Health Authority has worked to build trust by sharing power. While each of these examples involves some hard lessons, they all produced better and more equitable outcomes for people in Oregon once we listened and changed course. Let me start with Measure 110. In an about-face from decades of criminalizing behavioral health problems, state voters chose a new approach. They approved nearly $300 million in funding for new behavioral health resource networks, which would offer a comprehensive range of services from counseling to housing for people using drugs. These service networks would be formed in every county. Voters created a Measure 110 Oversight and Accountability Council to oversee the rollout and ensure people with lived experience and from communities most harmed by the war on drugs had a voice in funding decisions. No other state's ever attempted anything as daring as Measure 110, which reset our nation's decades-long failure to effectively treat substance use and stanch the damage that it wreaks on people's lives, families, and communities. Measure 110's gotten a lot of criticism, in part because it decriminalized drug possession before new treatment capacity became available. My agency, OHA, has caught a lot of flack for the manner and the speed with which we made money for services available. And there's a lot of merit in that criticism. As we grappled with a global pandemic, we didn't have the bandwidth to stand up the staff and systems we needed to quickly distribute Measure 110 money. Many people told us we should simply contract with established treatment programs and push money out the door as fast as possible. But you can't re-engineer a system overnight, especially if you want to get different results. You can't just upsize the current array of programs when those programs haven't worked for many people, when their workforce doesn't look like the people it serves, and when the established system has gaps in harm reduction, housing, and peer supports that hamstring effectiveness. Under state law, the Measure 110 Oversight and Accountability Council has more than a voice. Lawmakers gave it the authority to make final funding decisions. But when you do something for the first time, you're going to make mistakes. The Measure 110 Council was swamped by an avalanche of funding applications. They quickly learned they needed help managing a complex grant-making process. At OHA, we discovered that sharing power in a real way means you still need to give your partners a significant amount of support. Turns out that bureaucrats do possess important technical skills when you're trying to make fair decisions based on extensive applications about how you transform the delivery of substance use services across every county in Oregon. So we pulled staff from across the agency to review applications. We encouraged providers who'd never collaborated before to agree to link services. We helped county leaders bring housing organizations and peer programs together with traditional providers to wrap a more seamless continuum of care around substance users in their local communities. And we pushed money out the door as fast as we could while still honoring the Measure 110 Council's final decision-making authority. By the end of September, all $265 million in funding for Measure 110 service networks had been allocated. That's roughly 8 months later than originally intended. Because of the delay, it's popular to pile on Measure 110 right now. But lost in the rush to judgment are some important facts. First, a new study from RTI International found that the decriminalization of small amounts of drugs has not increased reported crime in Oregon, contrary to public perceptions. Reports of property crimes, disorderly conduct, and vice offenses were in line with what's happening in nearby states. Second, the public remains firmly behind Measure 110. Measure 110 passed with more than 60% support, and surveys show that current public support has barely moved. Most important, this is the moment Measure 110 actually begins. Funding is in the hands of local communities. For the first time, local providers have assembled a full continuum of services based on an aligned funding strategy and formal agreements. More people with substance use problems will get treatment and other services. Fewer will fall through the gaps in the system. We're testing the idea that sharing power will get more people into treatment and save more lives. And over the next 18 months, as these locally based service networks get up and running, we'll find out. But Measure 110 is only a portion of the investments we're injecting into Oregon's overextended and undercapacity behavioral health system. By the end of 2022, OHA will have spent or obligated nearly $1.2 billion of the $1.35 billion that Oregon lawmakers appropriated for the 2021-23 biennium to transform behavioral health, to transform the system. That's about 84% of the funds. The remaining money is scheduled to go out in the first part of next year as we wait for federal approval of new provider rates for behavioral health services, issue funding for more workforce incentives, and open the pipeline to more behavioral health beds. But let's face it, even these investments won't close what researchers at OHSU recently estimated to be a 50% shortfall in needed mental health services. It'll take sustained investment to ensure every county has all the services they need. but it'll take local voices and real decision-making power to ensure those services are acceptable, culturally responsive, and ultimately effective for the people and families who need them most. Now, I want to share another example of how listening to community has accelerated health transformation in Oregon, leveraging Medicaid to address the homelessness crisis. The Oregon Health Plan, our Medicaid program, provides health coverage to more than 1.4 million children and adults in Oregon. It covers 1 in 3 state residents. A hallmark of our Medicaid innovations is the flexibility we provide coordinated care organizations who manage OHP members for benefits to invest in what we call health-related services, such as nutrition and housing supports. These non-clinical interventions are aimed at the root causes of poor health, but Medicaid doesn't traditionally pay for them. Think of the proverbial air conditioner that a CCO could offer an elderly person with cardiac or pulmonary problems to keep them out of the hospital during a heat wave. In Oregon, a CCO can use a portion of their dollars for these health-related services. But in reality, CCOs have only spent a small fraction of their budgets on these types of interventions. According to an OHSU report, between 2014 and 2019, CCOs spent 1% of their resources to address upstream issues affecting the health of individual members. In 2021, CCO spending on health-related services increased by a total of $2.5 million across the system. However, that spending actually declined by $1.44 per member per month because OHP enrollment increased in that same period of time. Some people have blamed the state, in particular, our failure to win federal approval to fund CCOs through a global budget that would provide maximum flexibility to fund health-related services, instead of our current system of actuarially based capitated rates. But our federal partners have never allowed any state to shift from actuarial rates to a global budget. Despite that barrier, when we embarked on negotiating a new Medicaid waiver with the federal government, we heard loud and clear feedback in our community engagement process. People wanted solutions that would tackle the most pressing problems facing their families and their communities, such as homelessness, economic insecurity, climate change. They didn't care about funding rules or arcane health financing mechanisms. They weren't attached to one payment methodology over another. They wanted to live healthier lives. They wanted their communities to prosper. So that posed a dilemma. How could we use Medicaid to help solve the homelessness crisis and other issues, even if it seemed like our hands were tied by technical red tape? I'll admit, our team struggled at times when we heard community members ask to make the waiver and OHP more responsive to their needs. Our first reaction, honestly, was to think, how can we get community members to understand the intricacies of Medicaid rules? How could we get them to see that we've already pushed edges of what Medicaid could pay for in previous waivers going back 10 years? How could we get them to accept that Medicaid could only address the upstream drivers of urgent problems like homelessness through indirect means? But at some point, we realized you have to flip the question. Why couldn't we give vulnerable Oregonians Medicaid coverage for food, housing, health protections against climate change? Why couldn't we press our federal partners for approval for unprecedented types of Medicaid coverage, even if it hadn't been done before? Why couldn't we pave a new path for other states in the same way we piloted the coordinated care system? So, we hammered out an agreement with the Biden-Harris administration. State and federal officials teamed up to deliver a first-in-the-nation plan that will tackle the root causes of homelessness and get more vulnerable people off the streets and into safe, stable housing. Absolutely. Under this innovative plan, Oregon will be the first state in the nation to use Medicaid to pay for housing supports, including rent and moving assistance. Let me say that again. Oregon will be the first state in the country to use Medicaid to pay for housing supports, including rent and moving assistance. Why is this new plan such a big deal? It's no secret that homelessness is on everyone's minds these days. You see it in every community. People without a place to live because of a job that doesn't pay a living wage, or because of a health crisis or a mental health crisis has upended someone's life, or because a climate-driven catastrophe like a flood or a wildfire claimed the family home. Sometimes it seems like there are no solutions to these difficult problems But it's not true. Sometimes you need to rethink the old rules, especially if they're not helping solve today's problems. For more than 50 years, Medicaid has had strict rules that primarily limited coverage to medical care. Medicaid will pay thousands of dollars to cover an emergency room visit for a homeless person with pneumonia, but under traditional Medicaid rules, the program couldn't cover that person's rent, which would give them a warm, dry place to live and keep them from getting sick at a fraction of the cost of a hospital admission. For many people, housing is health care. You can't earn an income and pay rent if you're beset by untreated health and mental health conditions. You can't stabilize your health if you're living on the street. Imagine you're a middle-aged homeless woman trying to get by each day in Portland. You have PTSD from an abusive relationship, you struggle with heart problems and other chronic conditions, but you don't have a safe place to stay, to maintain your medications, you're malnourished. Housing is the key to your health, and recovering your health is the key that unlocks the door to independence and self-reliance. Under our new waiver, Medicaid can pay for up to 6 months of rent and other housing expenses, so you have a place to live, safely store your prescriptions, eat regular meals, find support from a mental health counselor, and heal physically and emotionally. Now your life is full of possibilities that were closed before. Here's another groundbreaking part of the plan. People who qualify for Medicaid and who are displaced by wildfire or other climate change-driven disasters can receive transitional housing assistance as a Medicaid benefit if it's medically necessary. In Oregon, thousands of people have been forced from their homes by wildfires in recent years. Even deep into October, from Portland to Oak Ridge, people are living under air quality warnings. Climate change poses a direct threat to human health. So we're taking action to protect people by extending Medicaid coverage to help people find housing if they lose their home in a disaster and they need housing to stay healthy. We also won federal approval to cover air filters and air conditioners as a Medicaid benefit to help vulnerable people and seniors stay safe from smoke and extreme heat. Now that air conditioner is a part of an OHP member's Medicaid benefit based on their medical necessity, just like a blood sugar meter or a cane. And our federal partners approved $2 billion in federal funding to help Medicaid coverage for housing supports and air conditioners work. Community feedback was the catalyst that pushed us to find these new answers. Now Oregon is back leading the nation in healthcare innovation. At a time when politicians are pointing fingers and blaming each other for homelessness, we're coming up with solutions that will make a real difference for many people, even if Medicaid can't solve the entire magnitude of the problem on its own. At a time when Oregon's healthcare system is struggling to overcome the financial strain of the pandemic, we've secured billions in new federal support, and trust was the key ingredient. We needed to live up to the community's trust that we would listen to their concerns and trust that community input would lead us to the right answers. Now let me share one more example that underscores how building trust and sharing power can directly eliminate health inequities and save lives. During the COVID-19 pandemic, Oregon has had a higher vaccination rate than most other states. The impact of our vaccine rollout is one of the reasons why Oregon has the second lowest COVID case rate per capita and the 8th lowest death rate among all states. It's why we've saved more than 5,000 lives in Oregon when you compare us to the national average fatality rate. And why the Commonwealth Fund ranked Oregon's COVID-19 response as the 5th best in the country. So many people in this room are an important part of Oregon's success story. So many of you, especially our hospital partners, organized immunization clinics and delivered vaccinations that have protected millions of Oregonians. But as our vaccination effort unfolded, the numbers told a disturbing story. There were big gaps in the vaccination rates between white people and people in communities of color. Once again, as with every health inequity, this wasn't a story about personal responsibility or individual choices to get vaccinated or not. This was a story about the impact of policy decisions. Federal and state vaccine prioritization policies privileged educated healthcare workers, teachers, and other professionals, putting them first in line, which advantaged white people. This was a story about access to healthcare. White people had higher rates of health coverage than Latino, Black, and Native American people, and so they were more likely to have established relationships with healthcare providers and therefore more direct access to a vaccine. This was a story about the legacy of racism and exclusion, a healthcare system that had historically failed to serve people of color, had earned wariness and skepticism at a time when trust and credibility were crucial. As Oregon's vaccination campaign sped forward through the spring of 2021, the disparities grew. The community was justifiably angry. Leaders from the Latina community held a news conference in Portland to voice their legitimate frustration at the widening gap for vaccination rates for their community. Black pastors wanted to know why our paid media campaigns weren't featuring the voices of faith leaders who had confidence of their communities. It was hard to hear those messages. Those were some of the most painful meetings I've ever been a part of in my public service career. The mass vaccination clinics our hospital partners had stood up had required gargantuan logistical efforts. Our outreach campaigns were based on extensive research focused on people of color, and they were reaching and engaging millions of Oregonians. But we needed to admit things had to change. We met with community leaders and set a goal to vaccinate at least 8 in 10 people of color. People said that was impossible. We knew the only way we could succeed was by working with the community. They said large vaccination clinics didn't work for many people. We needed more neighborhood clinics hosted by trusted local nonprofits. So we set up smaller clinics across the state. We provided more than $17 million in grants to CBOs for vaccine-focused outreach, in addition to more than $56 million in grants to nonprofits to address health equity. Community leaders also told us we needed to focus on providers with deep roots in the community, so we prioritized vaccines to federally qualified health centers that serve a disproportionate population of Latino and Latina patients. We opened eligibility to everyone they serve, regardless of age, occupation, or underlying health condition. Community leaders told us we needed to urgently vaccinate people who were most at risk, so we prioritized doses for migrant and seasonal farm workers who've experienced some of the largest outbreaks in the state. We heard the feedback from Black pastors. We adjusted our outreach strategy to give more prominence to their voices. We expanded our Ask a Black Doctor podcast to more radio stations. And it worked. Last month, we surpassed our target. In Oregon, more than 8 in 10 people, 81%, in the Latino, Latina, Latinx community are vaccinated, nearly the rate of white Oregonians at 82%. The change for Black, The change for Black, African American, and African immigrants was even more dramatic. Today, 95% of Black people in Oregon are vaccinated, far surpassing the vaccination rate among whites. No state in the country has posted a higher COVID-19 vaccine rate for the Black community. And thanks in part to feedback from Black leaders, our Safe and Strong public outreach campaign was recently recognized by Twitter as the most effective public health campaign in the nation, besting Washington, California, the CDC, and all other health awareness campaigns in audience engagement. These results show that health equity is not a platitude, an aspiration, or a vision. It's not just possible, it's attainable. And failing to achieve it is inexcusable. Can it be messy and hard? Sometimes. Will it take more time? Probably. Will it open you to uncomfortable criticism? Yeah. But the elimination of health inequity is not insurmountable. To get there, we don't need to embark on some perilously undefined and uncertain path. All we need to do is listen, trust, and act. At the Oregon Health Authority, we've set a goal to eliminate health inequity by 2030. But let's be honest. At OHA, we fund programs, provide health coverage, regulate services, we make policy, collect and publish data, and otherwise support partners. Well, our decisions affect the health of Oregon's 4.2 million people. We don't really treat many of them. Yet, as we've discussed today, OHA plays a major role in stemming inequity on many fronts, but we can't do it alone. We depend on you. Everyone in this room. You all have a role in making health equity a reality in Oregon, and therefore, you have a responsibility to eliminate inequity in your sphere of practice, whether you're a provider, an administrator, or an insurer. One step all of us have to take is to collect data based on race, ethnicity, language, disability, sexual orientation, gender identity. Then we need to comb the numbers, acknowledge the disparities, and act to address the underlying systemic inequities that impose harm on people's lives. I want to give you some quick examples that underscore both the stark urgency and the clarity of that imperative. Right now, we're working with hospital clinicians, community leaders, disability advocates, and medical ethicists to develop an equitable, non-discriminatory crisis care triage tools for hospitals to use if they ever become overwhelmed and cannot deliver life-saving care to everyone. We took a lot of heat for revamping Oregon's crisis care principles during the pandemic. Fortunately, Oregon's hospitals were never overtopped, like we saw in New York and other states. But for OHA, we believed it was important to hear the community voices that raised alarms about discriminatory factors embedded in Oregon's crisis care tools. And it's not just the tools Oregon's used. Healthcare decision tools are rife with structural racism. In a recent meeting, OHSU Dr. Derek DeVivier presented a New England Journal of Medicine article entitled Hidden in Plain Sight that examined the embedded racism in medical algorithms. Here's one example. The American Heart Association's Get With the Guidelines heart failure protocol automatically adds points to the risk score of non-Black patients. Those added points elevate the prioritization of non-Black patients to receive care and decreases the chance for Black patients to have their lives saved. I know our hospital partners are frustrated that we haven't finalized a statewide triage tool, but this example shows why it's important to interrogate those tools from multiple perspectives and scrub them of unintended inequities. Now, let me share some examples that show how a few of Oregon's FQHCs are using data to do a better job of treating patients of color and reducing inequity. Over the last few years, pharmacy residents at Virginia Garcia Memorial Health Center have evaluated hypertension screenings by race and ethnicity. They found that hypertension control among Black and African American patients was 10% lower than average. This year, the staff are working with a nurse practitioner to further evaluate contributing factors to hypertension rates among Black and African patients so Virginia Garcia's care teams can provide targeted education and reduce this disparity. Rogue Community Health, in addressing health disparities, reviews each uniform data system and CCO measure stratified by race and ethnicity, which includes reporting on colorectal cancer screening, controlling high blood pressure, A1C control, among others. The Reinhardt Clinic in Wheeler started a culturally specific food box program to help community members who are not well served through other food banks and food pantries in the area. Reinhardt's bicultural, bilingual outreach staff, who are also community health workers, have grown the program to serve well over 100 families across Tillamook County. If you're here today from a provider organization such as a hospital, a broader health system, or a clinical practice, ask yourself, what's stopping you from making these kinds of improvement in your practice? It's not just providers who need to take a hard look at the systemic inequities embedded in their policies and positions. Many of the people here in this room represent commercial insurers. How are you incentivizing providers in your networks to deliver more equitable care? In the Oregon Health Plan, we're incentivizing CCOs to ensure providers are giving patients meaningful access to healthcare interpreters. In turn, CCOs need to hold their providers accountable. That's how positive change can cascade through the system. Commercial insurers have a similar opportunity to look beyond cost savings in their partnerships and reward providers for improved health equity outcomes. Many people here represent CCOs. You're a vital partner in Oregon's health transformation. In 2021, on average, CCOs put 90 cents of every dollar into patient care. And CCO margins averaged a healthy 2.5% last year across our 16 CCOs. Yet margins ran as high as 11% for one large entity serving Medicaid patients and 22.5% for a behavioral health entity serving OHP members grappling with mental health problems. Last year, we also saw backsliding across the system in the CCO metric that measures patient engagement in substance use disorder treatment, which declined by 5%. At a time when Oregon's racked with behavioral health crisis, we need to maximize access to mental health and addiction treatment. We can't afford any barriers to care, especially for communities of color who already encounter a shortage of culturally responsive services. I know some have looked at the CCO 2.0 contracts as heavy-handed because they include new expectations to improve behavioral health services and increase investments in health equity. But without accountability, we'll risk getting the same poor outcomes we've been getting in key areas such as behavioral health. I'm going to say this very clearly. Oregon directs more than $7.5 billion a year in public money for CCOs to provide health coverage to more than 1.2 million vulnerable Oregonians. Our CCOs are financially strong. As representative of the taxpayers, health officials at OHA and elected officials in the legislature need to ask, can our CCOs do more to solve the behavioral health crisis? The answer is yes. Some people here represent local governments. You're also key partners, especially in public health emergencies like COVID-19 and in behavioral health. But we need to ask if the state's current open-ended funding arrangement for county behavioral health services is delivering equitable and effective outcomes for people who need treatment. The answer is no. We won't see better returns on the legislature's behavioral health investments until we have clear, aligned, and transparent outcome measures in state and local contracts. I know these are uncomfortable questions. I know the state and OHA have come up short as partners plenty of times. But you can't build trust without being honest. And the people of Oregon depend on all of us to do our part, not just the state. We all need to share accountability, and there are big issues facing our healthcare systems that we all have an interest in solving together. We need to provide health coverage to every Oregonian. That's why we'll continue to pursue federal approval for a bridge health plan and work with legislators and stakeholders on other steps to get us closer to universal coverage, which underpins the health and stability of families and communities. We need to curb the cost of health care. Oregon's the first state in the country to have an enforcement mechanism in its cost growth target. But we need to do more to address pharmacy costs, market consolidation, and other underlying dynamics that fuel healthcare inflation. We need to keep Medicaid on a sustainable foundation of funding. OHP isn't just vital for covered families and people, it's vital to every community. 1/3 of Oregon residents are on the Oregon Health Plan, and that rate is higher in many counties east of the Cascades. Medicaid expansion created more than 20,000 jobs in Oregon. We all need to work together to ensure OHP isn't disrupted by future funding cliffs. Finally, I want to come back to the biggest challenge, building trust and sharing power. It's not enough to open our boardrooms and public hearing rooms to more voices. We'll never get the results we want until the communities we are bound to serve lead the conversations and determine the solutions. At OHA, we've had our stumbles. We've learned tough lessons, but we're intent on eliminating health inequity by 2030 and all the intolerable physical, emotional, social, and economic burdens it imposes on people, families, and communities. There's no time to lose. There's no excuse to fail. And if we trust our communities to be our guides, nothing can stand in our way. Thanks.
I believe we have a few minutes for questions. I'm not sure if there are mics to be passed around or not. Oops, Heather. Oh, 1 minute coming on the mics. So, does anybody have questions? That would be the first issue. We covered a lot. Really appreciate it. Well, I'm not seeing any hands, so let me do this. Let me give you guys some time back to talk at the tables. But before I do that, I have just a couple of quick announcements.
Oh, we got a question.
Oh.
Housing component of CCO funding, how that might function.
How it might which?
The housing.
So this, hello?
Yeah.
Well, oh, there we go. Could you describe how the housing subsidy component of the new Medicaid waiver would function? Would that be functioning through the CCOs or some other mechanism?
Yeah, it becomes a Medicaid benefit like all the other benefits that we have. And so for the 85% or so of people who are on the OHP who are members of CCOs, that benefit would flow through them. That said, we have a little more than a year now to figure out what the hell does that actually mean, day in and day out, right? And there are some big challenges along the way. It's great to provide people with 6 months of rental assistance, but if there's no place to rent, it's not very helpful. And so we have to work in close partnership with all of our state and local partners who provide housing capacity to figure out how those things are gonna marry up. A year sounds like a long time to get something stood up. It's not nearly long enough. And we're gonna have to work really hard between now and 2024 to get those questions figured out.
And another question here. Ingrid?
Thank you. Director Allen, thank you so much for your thoughtful comments. My question to you is, over the course of your tenure at OHA, how have you viewed the role of the federal government in supporting you or not in your mission of building trust and sharing power?
Asks my federal regional administrator.
I asked you over the entire tenure of your service at OHA.
I think like most relationships, and I'm sure like many of our partners' relationship with us, there are good and bad elements to it, right? In general, I think, and depending on exactly what time over a period of time, our federal partners have been incredibly creative. I think, we did a lot of work at the local level around this waiver. They needed to say yes. They needed to work with us to design what these features look like. They needed to be willing to do this for the first time ever. The enormity of creating a Medicaid housing benefit, not discretionary spending or something that you could do, if it made sense, but it's a benefit of right to people who are in qualified categories on the Oregon Health Plan is huge. And I think we couldn't have done it, obviously, without the creativity of our federal partners. I think also when I look at the response to the pandemic, the willingness to sort of let's figure out what needs to get done to respond to the pandemic to give us maximum flexibility to respond, I think was extremely helpful. There are times when you run into a rule, and you wish you could figure out some way around it. But I'd say on balance, that's been much less an experience.
We're going to be talking in one of the later sessions about federal interactions, but certainly Oregon's one of the first to get this big waiver wave, but there are a couple others that have also come through in the last few months and are poised to come through as well. So we're going to be watching other states too to see how those conversations go and see what applies as well. Looks like we have one more question back there.
Director Allen, this isn't a question, it's a comment. As the chair of healthcare during all of the stresses during COVID, everything that you said just now to highlight everything that the state did with your leadership and others to save lives and get communities of color vaccinated, I just want to publicly thank you for all your hard work. We worked endlessly, and thank you so much.
Thank you.
Thank you. On that positive note, I look forward to seeing you back here at 3:30, and then from beyond that, thank you so much for your time and attention.